So we're going to go over the ventilator and the basics of ventilation. And this is just showing that it's basically like an air compressor in a way. It's going to push air into the patient, but a lot different pressures. The goals and objectives of mechanical ventilation is one, to promote safety for your patient, comfort, and ideally, everything we do on the ventilator is to lead to liberation or weaning the patient off the vent. So those are the main objectives that you want to think about when you're ventilating a patient. The goal is to facilitate release of CO2 and maintain a normal CO2. We do this by monitoring end-tidal CO2. How do we change CO2 in a patient? Basically, you can do that through the respiratory rate. So if you want to lower the CO2, you would increase your respiratory rate. And if you want to raise it, you would lower your respiratory rate. You can also change the tidal volume of the patient. Normally we do it with respiratory rate first, but for some reason, let's say you're using high tidal volumes, you can also lower your tidal volumes or raise them, whatever you're needing to do. And it's the same theory. If you use a higher tidal volume, you're going to get lower end tidal CO2s. And if you use a lower tidal volume, you're going to get higher end tidal CO2s. Minute ventilation is really important to know. When we get into ASV mode with the ventilator, which is a different mode that this vent has, you use minute ventilation. And minute ventilation is your respiratory rate times your tidal volume over a minute. You don't need to know the normal, ideal, whatever, but it is listed here on for you. And how you change your minute ventilation is either by changing your respiratory rate or your tidal volume. The other goal is oxygenation. So we want to maximize oxygen delivery to the patient, and this is measured in the PaO2. You can see it with your SpO2. And again, how do we change it? How do we make it higher? We probably don't ever want to make it lower, but you definitely want to make it higher so you can turn up your oxygen, or you can increase your PEEP on the ventilator, which should hopefully help get oxygen into the patient. Knowing if you had enough oxygen, if you are going on a really long transport, you can calculate out how to know if you had enough oxygen based on the cylinder type you have. You can use this fancy algorithm, but on this ventilator, you don't have to do that. There is a screen that I will show you during the example of the ventilator where you can know how much oxygen you're using per minute so that you can figure out if you have enough or not. Different modes that this ventilator does, and every ventilator does, is SIMV, which whether it's volume or pressure controlled. So SIMV is where more of a comfort mode for the patient. It allows them to breathe on their own, and it kind of substitutes what they're lacking. So if you want the patient to take 12 breaths a minute, and they're only taking 8, the vent will give them the additional 4 breaths that they need at the volume that you set or the pressure that you set. On the breaths that they take on their own, beyond the 12 breaths, it will let them take whatever they decide to pull. So let's say they're taking 16 breaths a minute, but you have 12 set. It will make sure that 12 of those breaths are at the volume that you predetermine or at the pressure that you predetermine. And then those other 4 breaths, it lets them, whatever volume or pressure they take is what they take. Assist control is a different mode where it basically, every single breath they get, they're gonna get that volume or that pressure delivered to them no matter what. So it doesn't let them breathe on their own at their own volume or pressure. It makes sure that it gets that same volume or pressure every single time. And then pressure control ventilation. So instead of setting a tidal volume, you're gonna say once the vent reaches a certain pressure, 20 is a pretty normal one, then that it's gonna shut off. And whatever the tidal volume they get with that pressure of 20 is whatever tidal volume they get. A different mode of ventilation, we use it a lot in small kids, is where we see it. And sometimes you see it in the adult world too. In assist control, the parameters that you would set would be the respiratory rate, the tidal volume, PEEP, inspiratory time, your oxygen, and then the trigger is just the breath recognizes, okay, you've started to take in a breath, and it recognized that you've started to take that breath. So then it's going to trigger the vent to give you that predetermined volume or predetermined pressure to reach. In pressure control, again, you're going to set your rate, your pressure control. I learned from respiratory a long time ago, 18 is pretty normal number to start out for just about anybody. So if you're putting somebody newly on pressure control, you could start at 18 and you could kind of see like what tidal volumes they get with that pressure and determine if you think it's enough. You can look at your end tidal CO2. Are they blowing off enough end tidal or enough CO2? Are they oxygenating well enough? And then you can adjust it based on that. We kind of say patients high pressure at 30. So if you're getting up towards 30, depending on what's going on with your patient, you may need to make some changes if you're getting up there in the high numbers. PEEP is, again, something you're going to set, and we'll talk more about that in a little bit. Your inspiratory time, your FiO2, pressure support. So in SIMB mode, if you think about somebody breathing through a straw, they would increase their working breathing. It would be really hard to like suck all that air through the straw. So what pressure support does is it kind of makes up the dead space in that vent circuit and gives them a little bit of pressure to help support their breath. And again, the trigger is just when it recognizes when you're starting to take a breath, and then it will initiate the vent to give the rest of the breath. SIMB, you're going to set your respiratory rate. Again, if they're breathing above it, that's fine. You're going to set your tidal volume or your pressure control. Your PEEP, your I time, your FiO2, pressure support again, and your trigger. Volume versus pressure ventilation. In volume ventilation, the volumes remain constant. So if you set it at a tidal volume of 500, let's say we're in assist control mode where it's going to get the same every single time. They will get that constant volume every single time. The pressure is going to vary based on the patient's compliance and resistance of their lungs, but the vent is going to give it that same volume every single time. It's more stable minute ventilation and stable blood gases because you're getting the same volume every time versus pressure control. With pressure control, it's going to give a breath until it reaches that certain pressure, and then it's going to shut off. So it doesn't care if your tidal volume's 300 or 400 based on your compliance and resistance of the patient's lungs and airway. It doesn't care. It's going to shut off and when it reaches that pressure. So your volumes are going to change and you don't get as stable a ventilation as you do with volume ventilation. Setting the tidal volume, it's something that's important that you'll set. The tidal volumes on the ventilator are defaulted at 6 mLs per kilo, but ideally in the adult and peds world, it's 6 to 8 mLs per kilo ideal body weight. So if you have that 5-foot person that's 250 pounds, you're not going to base it on the 250 pounds or kilos, change it to kilos. You want to measure their height and do it on their ideal body weight, because just because they're a heavier person their lungs don't change. If anything, they might actually get smaller as everything's compressed. And then attempting to keep the peak inspiratory pressure less than 30. So we kind of talked about that. Setting the respiratory rate, you need to think about the patient, what's going on with your patient. You know, are they in a respiratory or a metabolic acidosis and they're trying to blow off some of that CO2, so their rate is going to be higher. You kind of need to know what's going on with your patient so that you can anticipate the respiratory rate. And again, then you can look at it based on your CO2 and your PCO2 and decide what you need to change. Breathing is impacted by your IE ratio, where this is important as like your asthmatic. You don't want, your asthmatic is probably going to have a longer exhalation time because they're trying to blow off that CO2 and get those airways opened up. So you may need to change your I time, you know, and as you change your I time, it's going to change your expiratory time. So pretty normal is 1 to 3, 1 to 4, and that is changed based on whatever your rate is set at. So if you have your rate set at 12, that's going to be a different IE than it would be if you had your rate set at 20. Physiologic PEEP. So everybody's body has physiologic PEEP. It's made up with your epiglottis and your pharynx. Physiologic PEEP basically is what helps keep your alveoli open. If your body had to start over from scratch every single time, there would be some delay in the oxygen exchange that happens in the alveoli. So your body creates normal PEEP, and it's about 3 centimeters. That our body does for ourselves. So if you take an ET tube and you stick it down somebody's throat, you've now taken out their epiglottis and pharynx and you've wiped out their PEEP, which is why we set PEEP on every patient. Pretty normal is 5. In a normal healthy person, you will see in the adult world, I know for sure that we're using higher PEEPs when we're trying to oxygenate people, especially with severe disease lungs, that maybe they have a lot of secretions, whatever going on in their alveoli, they'll increase the PEEP, and we're even seeing PEEPs as high as 18 to 20. So don't be alarmed if you see a high PEEP, but just know that you've got to give them some PEEP to start with. You want those alveoli to be open and the oxygen exchange to happen there. Again, 5 is the most common. By increasing it, it's going to improve oxygenation by increasing your residual capacity. So again, opening those alveoli up and allowing the oxygen to exchange there. We also see this with clamping the ET tubes. You know, if you have a patient that's really sick, and let's say you go down and you suction them and you take that PEEP out for a short period of time, you'll notice it might take a while for their oxygen level to come back up. That's kind of your PEEP coming into play. They've got to open those alveoli back up and allow the oxygen exchange to happen. And so sometimes if we're switching somebody from one vent to another, and it's somebody who's pretty sick and you don't want to lose that PEEP, you can clamp off the ET tube while you do the exchange real quick so that you can keep those alveoli open and don't have to start over recruiting all over again. Setting your inspiratory time, I think we talked a little bit about this. It's basically normal is 1 second. If you've got an asthmatic, they might need a longer expiratory time, so you can change that on the ventilator as you need to. Setting your oxygen, the goal is to maintain 94% or higher. We need to reduce the effects of oxygen toxicity. So, you know, we don't want everybody sitting at 100%. Obviously, you're not going to do anything to lower it if they're 98 to 100. But if you've got somebody who's only like 89, 90, your goal is to get them to 94. Give as little as you need to get them to the goal. Pressure support, I kind of talked about this. This is the straw. If everybody were to take a straw and you were to breathe through a straw, you would increase your work of breathing. It's going to make it harder for the patient to breathe. They're going to have to work harder, and they're going to get sicker. So giving them some pressure support just kind of helps them so they don't have to work as hard, which is going to make it more comfortable for the patient, which is eventually going to lead to being able to get them off the vent sooner because they won't have to work as hard. Trigger determines the amount of effort required to trigger spontaneous breath. So again, this is kind of like a liters per minute flow trigger. So once they start a breath and the vent says, oh, we've reached, I think it's at defaulted at like 5 liters per minute, then it's going to kick in and give them the rest of the breath to help them out so they don't have to work so hard if you're in a mode that does that. Adaptive support ventilation. So one of the reasons we picked this ventilator was for a couple of reasons. It has this ASV mode, and this is a really nice mode. It kind of takes into account the patient's resistance and compliance, and works better to make it more comfortable for the patient. And then eventually, again, leads to getting them off the vent later in life or later in their stay. If you think about when you take a breath, you don't take the same tidal volume every time. You may not have the same resistance and compliance every time. So you're not going to achieve exact same ventilation every time. Well, the adaptive support ventilation kind of looks at that and allows the patient to take what they're taking, but kind of supports them enough to make sure they're getting the minute volume they need. So that's why it's kind of called like a pressure controlled minute volume guaranteed mode. Is it's going to guarantee that you're going to get the set minute volume every single time in that minute, but it's going to adjust, whether it adjusts the rate or it adjusts the pressure to get your tidal volume that you need so that you're hitting your goal minute volume every single time. In a passive patient, it works more as a pressure control mode. So it will basically say, okay, you've got ideal body weight of 80 kilos, and this should be your minute volume. The patient's not doing anything. So it's going to give a set rate based on the tidal volumes it's getting back. It's still going to allow the patient it doesn't want to reach over a certain pressure that you set. So it's going to give a breath till it reaches that pressure. And then it's going to look at the tidal volume that it's getting. And it's going to say, okay, well, I've reached this tidal volume. And so in order to achieve my minute volume, I need to make their rate this certain rate. So it will give the breaths based on that rate. In a pressure support mode, which is more with an active patient, it would work in a pressure support mode. So it's going to let the patient take all the breaths it wants, but it's going to adjust the volume that it's giving based on the rate that the patient's getting or taking, so that again, you achieve that ideal minute volume. Other controls, the expiratory trigger sensitivity. This is where the vent is preset. Once it reaches a certain percentage of peak inspiration, the ventilator shuts off the inspiration cycle, which allows exhalation to happen more passively with the patient. And then flow trigger is the patient's inspiratory flow that triggers the ventilator to take a breath. And we just talked about that a minute ago. P-ramp, this is pressure ramp. This vent was made over in Europe somewhere, so it has a bunch of different terms that we're not used to. Our vents do a lot of the same stuff, they're just termed differently. And on each of the ventilators, there's usually a cheat sheet that tells you what each of these parameters mean or these wordings mean. P-ramp is basically the time required to reach your inspiratory pressure to your target. So it's kind of like how fast the breath gets in. And then PASV limit is the maximum pressure to apply in ASV mode. So I talked about if the patient's breathing on their own, it will look at the pressure and get that minute volume. Well, it's not going to let you go over a certain pressure. And that's usually set about, the alarm will go off about 10 centimeters greater than the limit. So if you have your limit set at 20, you want it to give a limit or a pressure of 20, then when it hits 30, it's going to alarm at you. So you know that your patient's hitting some high pressures for whatever reason. You need to look into why. How do you know if your settings are appropriate? Well, you're going to look at your ABGs. Your VBGs are not as accurate, and your capillary blood gases, not quite as accurate as ABGs, but they're very close. I highly recommend to everybody, if you get a chance, to go to Peds ICU. They do a lot of capillary blood gases. If you warm really well and you do them appropriately, they're pretty accurate with your ABG. We don't want to arterial stick all these little babies all the time. So we do a lot of capillary blood gases. They're not easy. There is an art to doing them. Peds transport and Peds ICU nurses are really good at doing them. So if you get a chance to do one with them, I highly suggest that you take advantage of that. But then you're going to look at your acid-base balance, and you're going to correlate your end-tidal CO2, because you aren't going to get a gas every 10 or 15 minutes. How do you know what you need to change on your ventilator? Well, if you correlate your end-tidal CO2 with your PCO2 when you draw it, you'll know what kind of changes you need to make, and you can monitor that through your end-tidal CO2. Again, the goal is to choose the appropriate settings for each and every patient. Different diseases have different diagnosis and require different strategies. So knowing about your patient, knowing what's going on with them, are your high pressures normal? Do you need to set a higher PEEP? Do you need to allow for longer exhalation? Those are kind of things that you need to keep in mind when you're looking at vent settings and changing things. The other thing I also tell people, when I was switching to MedFlight, before I went, I was still doing Peds transport, and I was picking respiratory's brain Every time they would make a change, I would say, why did you change that? You know, explain to them up front, you know, I'm going to be in charge of doing ventilators and I want to know, I want to understand. And most of them are pretty good about sharing their knowledge with you, and they are very, very knowledgeable. So ask them what they're doing and ask them why and what led them to, you know, decide to do that. It will, the more you do it, it will give you a better idea and you'll feel more comfortable.